Hey guys, this is Dr. Shivek. Welcome to my YouTube channel. So guys, in this video, I'm going to discuss about a very important topic from the Electrolytes Abnormality series, hyperkalemia. So guys, what is hyperkalemia? As you can see, when the serum potassium level is more than 5.5 milliequivalent per liter, that is known as hyperkalemia. So what is a different etiology? First of all, when there is an increased uptake of the serum of the potassium in the form of IV fluids like isolate M. So isolate M has a maximum level of the potassium around 35 milliequivalent. As you can see here, this is the isolate M. And also, if the patient is taking the potassium containing drugs. Next, when there is a tissue breakdown causing the hemolysis, and due to hemolysis, what happens? There is a cell. When hemolysis occurs, the potassium go outside the cell, which causes the increase in the serum potassium levels. Also, potassium go out of the cell in the cases of like shock, acidosis, insulin deficiency, aldosterone deficiencies. Next, when there is an impaired excretion of the potassium. So, what are the different conditions causing this? Like renal failure, which occurs due to when the patient is on ACE inhibitors and NSAIDs. Also, Addison's disease and amyloidosis causes the impaired excretion of the potassium. Pseudohyperkalemia. What is pseudohyperkalemia? It is the hyperkalemia because of the traumatic hemolysis when we take the blood sample after the tying of the tourniquet causes the hemolysis and causing therefore increasing the serum potassium levels. What are the different clinical features? So first of all, there will be tingling around the lips and the fingers, hyperreflexia, gradual paralysis of the respiratory muscles, cardiac arrest in the last when their serum potassium levels is more than 7 equivalent per liter. So what are the different ECG changes? First of all, there will be tall T waves when the potassium level will be around 6 to 7 milliequivalent per liter. Then when the 7 to 8 milligram per liter is the potassium levels, there will be P wave will be absent and there will be white QRS levels. So in this ECG, as you can see, there is tall T waves which represent the hyperkalemia. When the potassium level will be 8 to 10 milliequivalent per liter, the QRS will merge with the T waves, and if by more than 10 milliequivalent per liter, there will be AV dissociation, atrioventricular dissociation. So how will you diagnose the hyperkalemia? So first of all, you will be measure urinary potassium levels. So in this we measure the transtubular potassium gradient. It is a very important. What is this? It is a driving force for the net potassium secretions, and normal value is 8 to 9. So we can classify in the two extrarenal causes and the renal causes. For the extrarenal causes, the TTKG will be more than 10 and there will be increased urinary potassium levels. And in the renal causes, there will be decreased TTKG and decreased urinary potassiums, and the causes are like Addison's disease and the potassium sparing diuretics. So which further causes the hyperkalemia. So this is very important slide, guys. Now, what is the treatment? So when the serum potassium level is more than 7.5 milliequivalent, first of all you can antagonize the membrane effect of the hyperkalemia by decrease the membrane excitability by giving the IV calcium gluconate at the 10 ml in 10%, which is 10% in 10 minutes. So it is very important, guys. So first of all, you should always stabilize the membrane potentials. Then we can give insulin and the salbutamol. So these are drugs which causes the movement of the potassium inside the cells, causing decreasing of the serum potassium levels. For glucose, we can give 25 to 50 gram of glucose with 10 to 20 units of the regular insulins, followed by D5 infusion at the 100 ml per hour. So this is very important, guys. Also, for the removal of the potassium from the bodies, we can give thiazide or the loop diuretics, potassium exchange resins like kexalate, hemodialysis, and the sodium bicarbonate infusions. Okay, so So this was the hyperkalemia, guys. Thank you. This is Dr. Shivek Singla signing off. Bye bye.